My name is Dr. Brian Durie. I'm a hematologist at Cedars-Sinai Comprehensive Cancer Center in Los Angeles. I'm also chairman of the International Myeloma Foundation. Well, this has been a great ASH year, and a great ASH for myeloma patients. So much new data has been presented. There have been major presentations related to frontline therapy involving the novel agents. And so at this particular ASH meeting we have follow-up reports about Velcade, about Revlimid and thalidomide. And these drugs have all now been around for several years, and so it's to the point of being able to assess what is the longer-term impact of those drugs in the phase 3 setting. In other words, how are these new drugs being integrated into the standard of care for myeloma? And so, as far as Velcade, for example, there were major presentations related to the more elderly patients over the age of 65, and there were several major presentations related to the management in the younger transplant-eligible group of patients. And so perhaps if we take those one at a time, I think that a major highlight of the meeting was the presentation of the VISTA trial. This is the trial comparing Velcade melflufen with melflufen. This large multi-center trial involving 251 centers around the world showed decisively not only that Velcade melflufen is better than melflufen, but that Velcade melflufen is a really remarkably good synergistic combination, which is setting the standard of care in the frontline setting for the elderly patient. And so now we are looking at combinations of efficacy and toxicity, quality of life in this patient population, because now we have several active combinations. We have Velcade melflufen, which is better than melflufen, but in parallel sessions we had very strong reports of melflufen plus Revlimid, melflufen plus thalidomide, and so we have right there 3 combinations of novel agents with melflufen, each with very strong evidence of benefit. And so we now are in the position of being able to look at combinations of oral agents, a combination of an intravenous agent, which is not necessarily so appealing for an older patient, along with melflufen, and look at different combinations of side effects. Obviously, with thalidomide, there's a concern about possible neuropathy. With Revlimid combined with melflufen, there's more concern about blood count issues. And with Velcade, there are concerns both about neuropathy and blood count issues. And so we're in a very favorable position, being able to balance and compare efficacy with different types of quality of life issues for the elderly patient. And for a patient who is eligible for transplant, transplant is still considered to be the standard of care in the frontline setting. However, there are strong data for a patient who might be proceeding with frontline transplant, but also strong data for patients who might want to delay the consideration of frontline transplant. Jean-Luc Harassot from the IFM group presented results with Velcade dexamethasone compared to VAD as frontline therapy, and was able to show that if this was followed with transplant, you could reduce the need for a second transplant. In fact, only about 30% of the patients who had the Velcade dex as frontline needed to have the second transplant. And so we're looking at a situation where now, with the introduction of the novel agents, the second transplant no longer seems to be so necessary. But in addition, we're seeing very high response rates such that the outcome is anticipated to be very, very good in the long term. And separately, we heard long-term follow-up data where the standard for transplant-eligible patients is right now that in the IFM 99 study, where we have long-term follow-up, 82% of the patients were alive at 7 years, so that we have excellent 7-year survival. And so that the consideration is now, what about Revlimid and Dex or Revlimid combinations in the frontline setting? We're seeing patients, 88 to 92% of the patients are alive and doing well at 2 years, at 3 years, possibly out to 4 years. Can this very, very simple treatment be sustained out to 7 years or longer, or is that really unrealistic? And so these are very exciting, although challenging times to balance the possibility of longer-term benefit with very simple therapies versus considering that maybe we still need to look at combining stem cell transplant with combinations of novel agents. And so for the patient with myeloma, there are options, but there are also challenges in thinking through what is best for the individual patient at this time. These are definitely exciting times for patients. These are good times for patients. Choice is good. It's important to have the options available, but I think it's also become critically important to have good access to advice and to be able to discuss carefully with your physician and with support groups. And certainly the International Myeloma Foundation provides a great resource to patients in different venues, providing educational resources through publications online and through our hotline services to help work through these different treatment options.